The problem with diagnosing depression. If you break a bone in your foot, a doctor may diagnose it with an x ray. If you slip a disc in your back, they may diagnose it with an MRI. But if you have depression, then it will not be diagnosed with a physical examination like brain imaging, but rather interviews and questionnaires. As the Harvard psychiatrist and neuroscientist Dr. Daniel Barron recently wrote, I am a psychiatrist in the 21st century, yet I still evaluate patients the way Freud did a century ago. I expect them to tell me what's wrong. And this type of subjective and unquantifiable diagnosis is not just limited to depression or mental illness, but for most of the neurological disorders that exist, which 1 in 5 people will experience in their lifetime, including dementia, epilepsy, and Parkinson's. The problem today with brain care begins with the diagnosis, as it's hard to solve a problem if you can't study and understand the underlying causes. In this case, the over 100 trillion neural connections in the brain. And even for the most brilliant, hardworking, and caring medical professionals, a multitude of economic and technological constraints within healthcare systems around the world has resulted in a large gap between what diagnostic tools they can currently provide to their patients on a clinical day-to-day basis and what is actually possible with even today's technology, such as what is currently used in research studies at elite medical institutions. What is currently being offered to nearly all neurological patients is essentially 50-year-old brain imaging technology, such as an anatomical MRI. And while things like picture resolution and 3D graphics have improved a lot, the technology is still fundamentally limited by the fact that it can only allow a doctor to examine the physical shape of a patient's brain. While this has some practical use for identifying the existence of physical problems that can be seen with the naked eye, like cancer or stroke, it omits all the information about the neural pathways responsible for cognitive functions, such as motor skills, emotions, and problem solving, and whether they're behaving normally or abnormally. So standard imaging offers little to no use for diagnosing most brain disorders. For example, a patient with severe migraines will sometimes get an MRI, but it's only to rule out the possibility of a different problem they can visualize, like cancer. A migraine itself cannot be identified and diagnosed this way. Let's now take a closer look at how doctors diagnose the most common neurological disorder of all, depression. As you can probably guess by now, depression patients would never be diagnosed with an anatomical MRI, because it's impossible with this information to distinguish between a healthy brain and a depressed brain. So how is depression actually diagnosed? Depression is commonly defined as having some combination of 21 different symptoms. Based on your reported symptoms and medical history, you will then be placed into one of 13 or more broad categories, such as anxious depression or bipolar disorder. In theory, if a person thinks they may have depression, then they would consult with a psychiatrist or other mental health specialist who would ask them about how they feel. They may also administer a diagnostic survey to inquire about which symptoms they have, with questions like, do you feel guilty some of the time, part of the time, most of the time, or not at all? The patient will try to answer these subjective and relative questions as best they can. If they score high enough on the questionnaire, then they have depression. That's how it's done in theory. But in practice, most depression patients never even see a psychiatrist. For instance, in the United States, 80% or more of depression medication is prescribed by a general practitioner, not a psychiatric doctor. They may not even administer a formal diagnostic survey, but just need to hear patients say that they have some of the common symptoms associated with depression. Diagnosing a brain disorder through patient self-reporting has its inherent limitations and flaws, and it also overlooks some of the biggest discoveries made in neuroscience and psychiatry. Over the past couple decades, there's been a massive amount of research conducted using more advanced types of brain imaging. Two of the most common types of advanced brain imaging are actually done using a regular MRI machine, but with different scanning protocols and software. These are diffusion tensor imaging, or DTI, and functional MRI, or fMRI. DTI shows all the different neural pathways, or brain tracks, while fMRI measures the amount of neural activity along those tracks. A simple analogy would be that DTI shows all the roads on the map, while fMRI shows the speed of traffic on the roads. Over 550,000 scientific papers have been published using DTI and fMRI. One of the most important studies ever done on the subject of depression used fMRI to better understand the brain activity of nearly 1,200 depression patients. The results were published in the top medical journal in its field, Nature Medicine, in 2017. Rather than placing patients into 13 broad categories based on an interview, we now know from the study that depression patients actually have a combination of around 7,200 abnormal brain connectivity features, some of which is the same as for anxiety patients, and that these patients can even be categorized or biotyped based on similar patterns of abnormal brain connectivity. It even went so far as to correctly predict how a patient would respond to TMS treatment based on their biotype. If you ask two different people about their depression, they will most likely describe their experience differently. And from a neurological standpoint, they will have a different combination of different connectivity problems in different parts of the brain. This helps explain why patients not only experience depression differently with different symptoms and severity, but also why they often respond to treatments like medication or TMS differently. So while technology has not yet matured to the point where we can diagnose a person with depression based on a brain scan alone, it can provide doctors with lots of useful information about which areas and networks of the brain are behaving normally or abnormally. So why don't all depression patients get advanced brain imaging? Well, processing and interpreting this type of data requires a lot of technical expertise and time. It requires a highly specialized knowledge of neuroscience and neuroradiology, the use of unreliable open source software, the need for coding skills, and each patient could take hours or even days. But perhaps most importantly, health insurance systems normally don't reimburse hospitals for these types of scans. So for the average psychiatrist or general practitioner who may see anywhere from 8 to 30 patients a day, it's not clinically or financially practical to do advanced brain imaging. They are essentially forced not to do so. So instead, this technology is still confined to elite research institutes, where they have more technical resources, time, and flexibility. And this situation is true not just for depression, but for all neurological disorders. However, recent developments in personalized brain mapping and machine learning technology is now making this type of advanced brain imaging more accessible and practical for the average doctor. If you'd like to learn more about the latest in brain mapping software, or more insight into how depression is commonly treated and how it could improve with today's technology, then please check out our other videos. Thank you.